Good evening, everyone. This is Julie Garceau for you for the next hour, and we'll be talking about tooth whitening, the science of it, and by the end, how we can get more predictable results. Myself, I'm a dental hygienist. I worked 6 years in a private practice, and then I worked for over 10 years with 20 different manufacturers, selling, doing product development for them, marketing. And one of the subjects that always came back when I visited customer and I spoke to everyone is we love the idea of doing tooth whitening. We understand what it is, how it can help us. But by the end, it doesn't really help if we cannot get the result we are expecting or that our customer are expecting. So tonight we'll be addressing this subject. This presentation wouldn't be possible without the help of several people. Dr. St. George from University of Montreal that have looked into my material and ensured that the science I was delivering was the right information. Dr. Tam from University of Toronto, same thing. Price at University of Halifax. The entire group of Catapult and all their very smart and nice dentists that work with them, PubMed and Quintessence, which are the publication I'm using also to get in touch with several researches on which I am looking and making sure that I am, again, delivering the best information as possible. In this presentation, you will learn how the tooth whitening product interact with the tooth structure and stains, overview different market options and how to make the best selection for your patient, and learn about tooth sensitivity causes and how to treat them. Well, first of all, we have to understand tooth color in order to make sure we prescribe the right product. The tooth color that we see is coming from the enamel color, the enamel translucency, and the dentin color. So as we can see, this is a picture taken with an intraoral camera, a fancy intraoral camera actually. As you can see, the grayish color we see at the tip of the teeth is not actually color, but it's more translucency. And that may explain sometimes patient insatisfaction after tooth whitening treatment. Tooth whitening doesn't actually color the teeth, as we all know, but it does remove stains. So it's very important we address the real concern before we start a tooth whitening procedure. The mechanism of tooth whitening consists in an unstable molecule of peroxide that breaks down into free radicals. These free radicals destroy large organic molecules chemically pigmented from the enamel and dentin, which breaks down into smaller, less colorful particles. This is what we're calling oxidation. Carbamide peroxide is, very simply, hydrogen peroxide compound with urea. It is also called urea peroxide. The urea serves no function in the whitening process. This means that essentially the active ingredient in both is hydrogen peroxide. So why not just using hydrogen peroxide? Well, that's a good question. It seems that urea added to hydrogen peroxide helps stabilize the formula, giving carbamide peroxide a more predictable and longer shelf life. The free radical breaking the bond between carbon will increase light intake but reduce color reflectance. The correct wording should be tooth lightening much more than bleaching or whitening. But hey, tomorrow we will not change the wording we're using for tooth whitening, right? But actually, this is what's happening. So hydrogen peroxides break down into free radicals, and those free radicals then work by breaking the carbon-to-carbon double bond found in the double-bonded organic stains in the teeth. Breaking these bonds leads to lightening of the molecule until they lose their color, typically over hours or weeks, depending on the manufacturer's instructions. If I may take an example, now let's think of an apple. Why is an apple red? Well, apple is red because of the light and because of its chemical structure. If you remove the light agent pretty much and you shut the light off, the apple doesn't have any color by itself and it will appear grayish. So tooth is the same thing. It reacts to the light, and by breaking those bonds, the light intakes of the tooth will be bigger or more important and will appear lighter after a tooth whitening procedure. Oh, that's a good example. Actually, that's a good image to illustrate what's going on when the tooth whitening agent breaks down into the patient's mouth. Enamel stains, original enamel color is affected and thus darkened by food, beverage, smoke, and oral hygiene habits. These normally would be treated with a standard 14 days whitening treatment, but careful, not everyone would take 14 days. There is not one recipe for everyone. We must be very careful about that. On the other hand, the dentin coloration could be caused by different things. That happens actually more internally. So dentin coloration can be caused by calcification. Calcification that can be coming from heat from, for example, smokers, you know, those people that keep pretty much a cigarette in their mouth all day long. So the heat coming out of that cigarette will create calcification of dentin. It can be caused by acid attack, lesion, erosion, abrasion. Dentin coloration can also be coming from systemic conditions. Medication, tetracycline, minocycline, genetic conditions such as defective amylogenes, fluoride trauma. Oh, and by the way, yes, I have a French accent, and I am sorry if some pronunciation are not perfect. I wish you can still follow. Anyway, there is writing on the slides, right? So that's the purpose of them. Age are also related to stains, and stains are related to age. And the aging people, including myself, will see our teeth becoming yellower or browner over time, and that will be, a combination of different factors, such as years of accumulation of intrinsic and extrinsic stains, the darkening of the dentin related to the recession and nerve blood flow or calcification of the dentin, and of course wear of the enamel layer creating more translucidity. Indication for whitening in general: any surface stains related to age, fluorosis, tetracycline, naturally yellow teeth, nicotine stains, of course before every aesthetic restoration, to match crown veneers to surrounding teeth, and from food stains. Unsuitable candidate, yes, there is some. Patient that would present excess recession on their teeth, excess abrasion or erosion, patients that are pregnant or breastfeeding, deep enamel fracture, patient with extreme sensitive teeth, patient that would have too many interior restoration, that would be less than 14 years old, that would have severe fluorosis, and more than everything else, patient that would have unrealistic expectation. Speaking of that, I don't know if you can see, this is an actual true publicity I have found on the internet from, I would not name any dentists in here, but they were advertising tooth whitening. And as you can see, this tooth whitening is very performing because it's also straightening the teeth. So, that being said, sometimes marketing doesn't help into creating expectation that can possibly be met at any time for some patients. So it's very important to level the expectation of the patient before providing a tooth whitening, so everyone is on the same page and everyone can enjoy the treatment. So doing the right evaluation will get you the best results. Both enamel and dentin color can be treated through oxidation or whitening. Enamel translucency can possibly appear more opaque from etching and dehydration while whitening. The enamel translucency will reappear under rehydration and remineralization. Thus, that will make patient believe that the treatment didn't really work well. So it's important to verify what level the translucency is. Speaking of false results, the effect of increased surface roughness is the dilution of the pigment color, that it appears lighter and less saturated. This is caused by the dilution of the diffuse reflectance. Okay, this is very fancy wording here. Anyway, what we're trying to see here is that there is a scattering of the light here, and the rougher the surface is, the greater the scatter, and the more important would be the reflectance, which means pretty much the more you hydrate the tooth structure, the more whiter it will appear, which is not a true result. Here is a very good example. As you can see on the picture, research in 2000 demonstrated that the application of a rubber dam alone would cause a lightening of the tooth of a delta E of around 6.26, which means that approximately 6 to 12 shade on a Vita Classic shade guide, depending where the tooth color measurement begins. But as you can see, all those grayish color you can see on my slide are the same exact color. But because the texture difference, the texture in matte appears much lighter than the glossy one. So by the end, what product shall we choose? There is so many out there, and we'll look into that later. Golden rules number one. The result of the whitening is directly proportional to the compliance of the patient at respecting the contact time and at doing it on a daily basis. Meaning that if your patient is going to do it once in a while, well, guess what? You will never reach the result you are looking for. Golden rule number 2. Result is related to the number of application, time, and concentration. Golden rule number 3. We must have a minimum of 10 to 14 applications to achieve a long-lasting result. I have a question here asking, can you block recession teeth and whiten the teeth if the process or it will cause sensitivity still? Yes, you could make a decision to actually block the recession and still whiten the teeth. You need to be careful to see at what level the recession is. It's over the enamel and cementum junction, it's fine. But if it's a recession that has taken part into the actual crown of the tooth, I would not recommend such a thing. Tooth whitening diffuses through the tooth structure very well, and I would be afraid that this diffusion would extend to a level where the tooth is no longer able to support such a treatment. So many formula out there. Hydrogen carbamide. Hydrogen concentration, you would have all take-home product. You can find them on the market going from 3 to 15%, strip from 3 to 14%, and in office, or what we're calling chairside product, going from 25 to 40% hydrogen carbamide. Carbamide product, you would find product going from 10 to 35%, office booster that would be around 35%, and pharmacy, which I'm calling tree-like product, with unknown percentages. I can see that there is more questions that are being added here. Just to let you know, the last 10 minutes of this presentation will be strictly dedicated to answer all questions you may have. Which concentration then should you choose? A high concentration of peroxide does not whiten the teeth more, but it will whiten them faster, limiting contact time between the product and the enamel. So that is a very important thing. In the presence of water, carbamide peroxide degrades into urea and hydrogen peroxide at a ratio of about 6.5 urea to 3.5 hydrogen peroxide. This means that a 10% carbamide peroxide gel is equivalent to 3.5 hydrogen peroxide gel in terms of its bleaching effectiveness. An important difference is in the two concern the rate that each releases hydrogen peroxide. Carbamide peroxide is a more stable molecule and it therefore breaks down more slowly than straight hydrogen peroxide. Carbamide peroxide releases about 50% of its peroxide in the first 2 to 4 hours. Then the remaining will release for the next 2 to 6 hours. It acts in more of a time-release fashion. Hydrogen peroxide breaks down almost immediately, releasing its peroxide entirely within the first hour. It is thought that due to this immediate bombardment of peroxide on the pulp, hydrogen peroxide produces more sensitivity than carbamide peroxide or a comparable concentration. So what would be the advantage or disadvantage of each other? Well, hydrogen peroxide has the advantage of a shorter contact time. It could be used daytime quite easily because of its short contact time. And actually, there is nowhere in the law of tooth whitening that says that someone wouldn't be able to do multiple applications. Carbamide peroxide has a slower release. It means possibly less sensitivity. It can be worn overnight and greater stability of the product from a more complex molecule. How about the effectiveness? Well, a double-blind in vitro study that was conducted in 2000, September, by Dr. Cochrane, Eckert, Mattis, and Morklis. 20% carbamide or a 7.5 hydrogen peroxide twice a day for 14 days. So we're over here with two equivalent products in terms of effectiveness. The conclusion of that research showed that the use of the 20% carbamide resulted in significantly more lightness than the 7.5% hydrogen peroxide during the first 14 days of the study. At the end of the study, though, there were no significant difference between products with regards to tooth lightness. In addition, the author found that no statistically significant difference between products with regard to gingival or tooth sensitivity. So what pretty much this is saying is that no matter which one you're going to use, if the product has to work, both products have the same ability to provide you with a good result. And in reality, the carbamide peroxide has to remain in the mouth for a little longer than hydrogen peroxide. And that may explain that the tooth may have looked whiter because of the dehydration and the fact that the product had to remain on the tooth surface longer, and thus priving that, making that the tooth couldn't be in contact with the saliva and all the buffer agent within the saliva. But that's just a theory, right? And how about in-office whitening? Oh, I love that subject. Are they relevant? Are they effective? Is the light really helping? Are they safe? And how about the combined technique? Well. First of all, speaking of satisfaction, in 2005, so this is an older research though, the respondent satisfaction with in-office bleaching, well, only 16% of users were very satisfied. 30% were satisfied, unsatisfied 23%, and very unsatisfied 5%. What is that saying? Well, it depends on what expectation you've got from such product, and we're looking to that. Well, then, how about the light? The light does speed up the hydrogen peroxide reaction. Some manufacturers will incorporate pigments or chemicals to help the absorption of the light. Unfortunately, this is not improving the ability of the tooth structure to absorb or diffuse the product. To better understand how a light source can dehydrate teeth, its theory must be explained. When undergoing a light or laser teeth whitening procedure, the light hits the tooth at a very high intensity. The bleach on the surface of the tooth boils off in the air, which is the path of least resistance. Some bleach will actually infuse into the teeth and allow for some actual bleaching. As the light illuminates the tooth, darker colored part of the tooth absorb the light rather than reflect it. This absorbed light is converted into heat energy. Areas of the tooth like the pulp chamber and dentine are darkest, so they heat up the most. This causes the tooth to heat up from the inside. As the tooth builds this uncontrollable internal heat, fluids in the pulp and dentine expand. This expansion pushes water out of the tooth through the protein matrix surrounding the enamel rod. And that explains why so many lights create tooth sensitivity, gives you the illusion of tooth whitening. We looked into that earlier, right? About how dehydration creates this illusion of tooth whitening and how much that can make a difference on the VitaShade guide, right? Here is just a different light sources that are used out there for tooth whitening, and they have been actually rated from on the top the most hot light, or the light that created the much heat, and then at the bottom the one that creates the less heat. A CRA survey in 2005 compared the usage of home tray bleaching with in-office bleaching. And they asked the reason why dentists are using the light. And that's very funny. Some dentists stated that they used the light because it came with the system, so they didn't even know they could buy some tooth whitening that didn't came with a light. Some used the light because patients are just asking for it, and we all know that this company that started with a Z was very, very good at creating an inverted market where they were appealing to the end user of the product. And some because it's just good for marketing. But we need to be careful about it. We must not overlook in-office too fast. First of all, there is possibility for treating non-compliant patients. You know, some people are gagging like very severely when we try to take an impression, and that could be an option. Don't forget that when you're doing in-office, you're working in a very controlled environment, because the gingival barrier will be covering, actually, well, like the lady that was asking earlier, we can pretty much block any recession, we can block the gingiva, we can block every environment where we don't want the tooth whitening to be in contact with. And in some situation, a combined technique creates an increased motivation and possibly shortening the treatment time as well. So how effective it is in reality? Well, researchers in 2010 has shown that one appointment is in general equivalent to 5 home applications, which means that really if you schedule your patient for 3 appointments of in-office whitening, no matter how much you're going to charge some patient, you know, that we can judge how much people can decide to spend on tooth whitening. But after 3 appointments, you will have around the equivalent of 15 applications at home. And we all, we've seen that generally 10 to 14 applications can bleach much of the most general stains on teeth. And it can be combined with take-home bleaching for better results. So overall, in-office tooth whitening has some, you can do it. And it's a good treatment. You just need to pace your expectation. This is not a single treatment. You need to combine it or do multiple appointments, but it can be something good for your patient. Things to consider for your success. The longer the stains have been embedded in the tooth structure, the longer it will take to remove them. The deeper the stains are, the harder it will be to remove them. And most of the stain can be bleached. Patience is required for dentin-related color. Be prepared for up to 6 months of whitening to achieve satisfactory results. Of course, we're talking about very severe cases of fluorosis or some, well, actually not fluorosis, but brown staining from bruises, not pits though. Or we're talking about very severe cases of tetracycline stains. We were talking about the patient motivation of doing it on an everyday basis and being committed to it. Things you can do to have your patient motivation more important is shorten the time in the mouth. Then maybe using hydrogen peroxide could be an option. Making sure that your patient is comfortable, shortening the treatment time. Again, if you're working with hydrogen peroxide, which I'm a fan of, you can do multiple applications in a day, which makes, the treatment much less longer, especially if you're working with patients that have harder stain to bleach. Get the patient involved and responsible, and you can decide to do the first treatment in office on the chair or simply with their trays at the office. Then the study and the reality of some information that are being spread around heavenly. There is a difference between in vitro and in vivo. Well, in vitro are showing that carbamide remains active up to 10 hours. The reality of it is that the saliva is washing away the material in the trays, and the material availability is subject to patient salivation. So again, sometimes faster is better. Slow release of iron from low concentration being less aggressive on the tooth structure. which would be equivalent to less sensitivity? Well, again, the lack of comfort related to the long wearing of trays and microorganisms and loss of enamel due to extended contact time could be a problem. Actually, a review of all the clinical trials on whitening indicated that 25 to 75% of the treatment group receiving active ingredient of peroxide experienced sensitivity. Interestingly enough, though, 20 to 30% of the placebo group not receiving peroxide experienced sensitivity. So just wearing a tray alone can produce about 20% sensitivity. That's a very funny. In vitros are showing that possibly you can extend the treatment up to 6 months, but the reality is the follow-up required is not compatible with the private practice for most of you, and patients are not necessarily compliant. The other thing we have to consider is the tray design. So, does that really matter? Is that going to make any difference? Ideally, the material should sit on the model for 24 hours to avoid distortion. Why is it? Because if you remove the material of the model, it's going to be all twisted and the fit will not be good, and thus, of course, material can spread out of the trays and get into the patient's mouth. Reservoirs are a good thing, and I'll show you why after. And scalping, which I mean contouring, is essential to avoid gingival irritation and excessive material into the sulcus environment. Over here I have a ideal Dyson design tray. So what you can see on the upper part is the tray have been very well scalped around the gum. Over here, let me show you. Over here. So it's been very well scalped. Here, here, and here. But in the back, here, it's going over the gum. Why is it? Well, this reason is for the tray retention in the mouth. Second is for the patient to give the patient an indication from where to where he needs to apply the gel in his trays. There is no need to apply around the molar. Even if it's Julia Roberts sitting on a chair, let's be honest. Even if she smiles up to the 8 in the back, okay, she smiles to the last molar, it doesn't change anything because the shadow from the cheek will not make anyone see if it's bleached or not. And most of the molar have been treated, got cracks in there, got recession on there. There's a lot of stuff going on in the molar. So please just forget about the molars and let's not waste the material, and let's concentrate on teeth that matter, which are the one in the front, premolar to premolar maximum. Then the last reason why you would have a tray design like that is because of that saliva canal coming out just up at the 6. And by doing that, you're avoiding much of the water or the saliva to be ejected within the tray. And then you're not mixing your saliva with the gel. And that's another advantage of it. Evaluation of variation of tray fabrication. In vivo cross-arch design. 15% carbamide was used for this research. And the colorimetric analysis showed that the side that was whitened with a reservoir were lighter in color than the other side. But it was difficult to see with the naked eye, so just do whatever you want. I would rather have reservoir. And there is less amounts, of gel that would be lost in the oral environment. All 9 products tested degraded at the same rate. Total recovery of carbamide peroxide was significantly higher when reservoirs were placed in the trays, and more carbamide peroxide is ingested when used in tray without reservoir. So to me, those are arguments that makes me believe that taking the extra 3 minutes to put reservoir on your trays is worth it. Then there is a sensitivity factor. If you want your patient to be comfortable, if you want to have a good reputation, if you don't want tooth whitening to become a headache for any member of the team, these things should be addressed. Sensitivity factor could be dehydration, the product formula, the concentration, the pH of the product, the condition of the tooth, or the tray design. How do we control that? Well, first, choose a product that has at least 20% water. In today's world, a lot of the product out there are principally or mainly made of glycerine, glycerol, or any type of glycerine products. Ladies, glycerine is a dehydrating agent. It's put there to put texture in the product, but also to get rid of the excessive saliva on the tooth structure and enhancing the contact between hydrogen peroxide and the tooth. It's not a bad thing. But on the other end, if you only have glycerine and no water, you're going to have excess dehydration, that osmotic reaction we talked about earlier, more sensitivity, a fake white result. And just as another little thing, you know, cream, body cream, facial cream, look on your little expensive jars. Most of them have glycerine. And really, the more you put cream on your body, the more dehydrated you are and the more cream you need to put on. This is all addictive. This is the Coke situation, you know, speaking of the pop, actually. And continuing on that, so choose product that has less than at least 20% water, neutral pH, incorporated desensitizing agent. Studies have shown that if you have a desensitizer agent within that travels with your peroxide, it will be more effective. Reduce the contact time, work with concentration that are medium or low, and overnight treatment is not for everyone, especially if you have problem of TMJ problems, teeth grinder. Listen, this is going to be terrible. Product formula, why is that makes a difference? Since hydrogen peroxide breaks down to a faster pace compared to carbamide peroxide, the ions are bombarding the tooth faster, increasing the irritation of the tooth structure and possibly increasing the sensitivity. But what we talked about, it's not always true. See what we were on to talk about. Tooth dehydration. It's caused by the use of a light or heat. It's caused by the addition of glycerine-based thickening gel and overnight or extended wear time. But at the end, why is it hurting? Why is the tooth hurting? Well, there is two considerations why teeth are hurting sometimes when we're doing tooth whitening. First is a mechanical consideration. A greater porosity of the tooth structure is increasing the sensitivity to the tooth structure to thermal stimulus. The second point is that the negative osmotic pressure into dental tubules from tooth dehydration. So we have different type of desensitizer. I have too many slides on that actually because this is like a new trend coming out of all sorts of desensitizer. But really, what you have to remember is you have two family of desensitizing agent. The one that are a mechanical desensitizer that are addressing mechanical type of problem, like we saw earlier with our open tubulus and so on. So what kind you have? You have all sorts of remineralizing agents such as Ricaldin, fluoride, Novamin. And then what do you have in fluoride? You have sodium, stannous. And by the way, stannous stains the teeth, right? And it has an acid pH, so not recommended with your tooth whitening. Aciding your pH will slow down the tooth whitening. It will change the way that your ions are released, and this is not recommended at all. You have those products that are made of argon at 8%, especially Colgate products. You have Novamin-based products, Sensodyne and Expure. You have products that are containing Ricaldin, like MI paste, and some products are containing strontium acetate, which is Sensodyne Rapid Relief. And there is more product on the market, but I could do an entire presentation just on that. But really, every product we just talked about, those toothpaste, are mechanically active, right? Now you have the chemical problem, the chemical pain. Well, actually the pain that comes from the verve, and you have the chemical desensitizer agent. Mainly what you've got is potassium nitrate and ibuprofen. Potassium nitrate penetrates the enamel and dentin to travel to the pulp and create a calming effect on the nerve by affecting the transmission of the nerve impulse, so the excitability of the nerve is reduced. Potassium nitrate almost as an anesthetic-like effect on the nerve. It makes the ultimate adjunctive to the tooth whitening. And, a couple weeks ago, I was in college, I was speaking to the teacher. I mean, every single year they bleach all the dental hygienist teeth, and she said every time they experience sensitivity while bleaching, all those mechanical desensitizers don't really work well. What works is potassium nitrate, and really, especially if you're going to in-office tooth whitening, ibuprofen as anti-inflammatory would do the right job. But, tooth sensitivity is something that needs to be addressed before, during, and after treatment. So if your patient is sensitive before you start, well, before treatment, pre-brushing with a potassium nitrate toothpaste 2 weeks prior to starting the treatment has proven to reduce incidence of sensitivity. And this is what you have on the slide here is research made by and paid by Sensodyne. But actually, it seems to be working very well. Some example of toothpaste that have 5% potassium nitrate you have Colgate for Sensitive Team, Arm & Hammer Sensitive, Sensodyne F, Prevident 5000 Sensitive, and Crest Sensitive. And sensitive teeth should be treated with remineralizing therapy. It could also be novamine fluoride, CCP, or ACP. So what I'm saying is that, yes, you can prevent, but if your patient is sensitive, remineralize before you bleach. And any of those fluoride, novamine, I don't have a favorite. Just use the one you're most comfortable with. Then, while doing the bleaching, you must use potassium nitrate. If your bleaching doesn't have it already incorporated, some do, as SDI, for instance, they do have potassium nitrate incorporated in their gel, but you might need extra. So here is a list of products that do have it. They have in a 5% with relief at Discus Dental, 5% at Denmat. Ultra Ease from Ultradent has only 3%, and Soot from STI has 6% of potassium nitrate. The difference is that those products they're more effective because the contact is maximized by the nature of the product. Its non-foaming formula and high viscosity prevent loss in your oral cavity. Most importantly, patient calling in the office should be viewed for a diagnostic of the origin of the pain. If your patient is still sensitive after the treatment, for in-office tooth whitening, the usage of Advil of ibuprofen is very, very, very recommended. The rapidity of action and instant relief potential of potassium nitrate gel makes it a very good complement to any desensitizing therapy. But finally, if required, a remineralizing therapy is helpful. It can prevent immediate staining of freshly whitened teeth. And in this case, I have heard from a lot of my customers that the MI paste is very effective in that matter. Then, we can't talk about tooth whitening without talking about all those new whitening trends. Listen, I mean, this is a very lucrative business. Everyone wants to have a share of the pie. Everyone is looking for the miracle solution. Everyone, manufacturers are reinventing themselves to find their way in the very lucrative and competitive market of dental whitening. So, what's new? Well, there's different trends we're hearing about, such as deep bleaching, Trusil tray, hydramid, anything. So, what's true about that? First of all, deep bleaching just means that you do whiten the teeth from side to side, going from enamel to dentine to pretty much the pulp. Any regular take-home can do that kind of deep bleaching. It just needs to be worn on an extended period of time, meaning weeks, until you achieve the result you're looking for. That's what deep bleaching is, really. Then you've got the seal tray. The seal tray is this is another popular trend right now. It's very expensive because all the lab has to be done outside your office, and this is not just your average lab that can do them. You have to send them to a specific lab. And apparently what it does really is that it prevents the saliva to wash out the product, but also to bring in a and lower the pH, which would change the way the product reacts and the availability of the free radical to break down those carbon bond from the stains. Well, actually, at this point, no clear evidence of increased lightness have been shown in regards to that kind of technique at this. So, be aware of that. There is also on the market a new type of light that is infrared light that is being used with preform tray, normally 35% carbamide, and would be used 20 minutes at every recall. Most of it comes from immediate dehydration, very little improvement, no more effective than mall type of whitening, okay? Then I'm being asked on a regular basis what is being recommended for non-vital bleaching. For a long time, superoxide and hydrogen peroxide were used, but the trend now is to use carbamide peroxide that has a very low level of extra-radicular diffusion, and so it is now recommended as an alternative that is not as aggressive. I'm also often being asked if tooth whitening are safe. Just for you to know, toxicity of hydrogen peroxide is not a factor, and the effect of, and what about the micro-hardness of the tooth structure? Well, here is a couple of very important information for you. First of all, our own body produces a large amount of hydrogen peroxide and other oxidative chemicals, primarily in the mitochondria during oxygen metabolism every day. The adult human body produces about 650 milligrams of hydrogen peroxide per day via oxygen metabolism. 2 bleaching trays with reservoir with 16% carbamide peroxide contain a total of 6.5 milligrams of peroxide. This means that our bodies manufactures approximately 100 times more peroxide every day than the amount that is put into the upper and lower bleaching tray. So we do have everything it takes to digest that peroxide, including an enzyme called catalase that will digest it. So no worries about that. Then some other concerns are regarding the micro-hardness of your enamel and how that could be lost. Studies have shown that most of the product will reduce the micro-hardness of the enamel to a certain extent. Main factors are influencing contact time and pH. And among all products tested in the in-office one, did not affect the micro-hardness at all. And in this research, it was the product from Ultradent, Opalescence Extra Boost, 38%. Among all products tested, the greater loss, so the most important loss of micro-hardness was with Night White ACP at 10%. So, interesting fact, the less powerful product was the one that was creating the most loss of micro-hardness. The study is suggesting that it might have been because, one, of the increased contact time, but also because of the pH of the products. And the fact that the Opalescence Boost product has almost a neutral pH, and that the contact time with the tooth structure was very short. How about over-the-counter products? Oh, well, this is very hard to follow. We've seen strips, preformed tray gels, pens, toothpaste, rinse, all sorts of products. What is good to know is the pH variance in preformed tray product is very high, from 3 to 11. Paint-on products can contain whitening effect products going from citric acid, also for conservation, to dioxide titanium, which is pretty much white pigment. But like I'm saying, very important, first of all, citric acid will etch your tooth structure, will increase the loss of micro-hardness, but on top of that, it creates a false result of whitening by creating that etch effect, right? Toothpaste and rinse are mostly make-you-feel-good products that have no effect. Abrasiveness of toothpaste can be a concern depending on the brand. As for whitening strips, well, it's a well-understood chemistry. It's made of hydrogen peroxide ranging from 12 to 14%. The delivery of material leads to a greater loss of peroxide into the oral cavity, but the cost effectiveness of this method is not ideal over time because every time you have to do touch-up, you have to buy a box, and they're not cheap. Carrying the idea that tooth whitening does not require professional assistance is a concern to me, okay? And saying, just do white strip, well, exams and cleaning and should be done before you do tooth whitening. Finally, very importantly, a very thorough assessment of the tooth whitening, or actually a good exam of teeth, should be done before. And this is one example of assessment I've been designing with SDI before you do whitening. That is addressing the patient habits, the condition of the teeth, what are the expectation, what will we do in terms of follow-up. And this is to make sure that everyone in the office will consider, treat, and address tooth whitening in the same professional way. Patient's instructions should be given. That should be including to keep the whitening gel from exceeding 23 degrees Celsius, to not skip treatment, brush teeth after eating or drinking highly colored food. Why don't say to not eat any colored food at all? I think it's not realistic to ask patients for weeks to not eat anything colorful. Anyway, when you do your next application of tooth whitening, the few maybe little stain you'll have will go away. Where it's important is that 48 hours after the last treatment, this is where you really don't want to have any colorful going on. Smoking will affect the result. Staining food eaten in the first 48 hours, yeah, that's what I was saying, can affect the result. Do not put any other product in your trays beside those provided by your dental professional, very important, and call the office in case of any major discomfort. By the end, a successful whitening department requires to build a good protocol, including sensitivity control. It also means that you have to have a well-trained team understanding the chemistry for better product choices. Patient well-informed with realistic expectation, and that starts with a good assessment and protocol and result recording in your office. And at the end, a product offering that suits patient need and lifestyle. And having different menu could be a good idea and not a one-size-fits-all recipe for all your patients. So we'll move to question and answer mode for the next 10 minutes. So I have multiple questions here. Will you talk about, oh boy, okay, I'm just trying to follow here. Can you give the patient NSAIDs prior to treatment to reduce pain from whitening? I'm sorry, NSAIDs prior to treatment to reduce. I don't know what medication you're talking about. I would not necessarily recommend that, because what you don't want to do is actually kill the pain. And how about if the pain is not created just by the tooth whitening, but it's created because you have a broken filling in the back or a very important crack in the crown, and you're getting a problem with your tooth whitening. So I think that the pain should not be killed totally before you do a tooth whitening to avoid any problems. How old should a patient be to have bleaching done? I would say that normally we say 14 years old, or if you want, we can say 2 years after puberty is over. Oh, thanks for the doctor or the person that just informed me that NSAIDs means Tylenol, Motrin, or Aleve. Thank you for that. So no, again, maintaining that I don't give any drugs before a treatment unless it's very necessary. We want to be aware of the level of the pain before prescribe anything. Can night guard works as whitening trays? Normally night guards don't go over the gum line, so that's why they wouldn't be the best. if they were designed differently and the material would not be disrupted by the tooth whitening, I don't see why it wouldn't. We need to make sure that they're being cleaned properly between each application. Thank you. I'm having your presentation has been the best I ever heard. Thank you so much. I have so many questions coming in. I'm trying to keep the pace. Oh, wow. I know that a very exclusive manufacturer, you said, is sending frozen, I guess you would say, tooth whitening. Bleaching material, though, better conserve oxygen concentration. If this works better or not, it's very expensive. Yeah, I know who you're talking about. I've been studying that very carefully. Well, actually, you know what? They do a big deal of that. Actually, it's not frozen, but it's being kept in the cold, very cold. It does help to have a maintained environment, but some other company, and I don't want to sound like a publicity, but SDI, for instance, does the same. They never made such a big deal about it, but their products are much more affordable, and they are being produced in a cold plantation. It's been shipped in a refrigerated container, and it's being sent into cold trucks and maintained in a refrigerator at the dealer. So really, the product doesn't get exposed to heat along the way until it gets into your office, and then it depends on your storage. So, you know, some companies are using that kind of statement to make marketing. Yes, it does help, but they're not the only one at taking such a care. So, at 14 years old, can one use hydrogen peroxide? Absolutely. Hydrogen peroxide is not more harmful than carbamide peroxide. Actually, like I'm saying, I do love the idea of the hydrogen peroxide just because it doesn't remain in the mouth for such a long time, so that's much less swallowing of the product. If a patient has a sensitivity during in-office, do you stop and reschedule? I would see what's going on first. Most of the time, I've been performing around 400 in-office treatment in my career. I would say most of the time it's due for a gingival barrier not being carefully applied. So if it's sensitive, I would try to identify where it is sensitive. I would suction off the material, the gel at that place, take a second look at the gingival barrier, reapply, recure that gingival barrier, or look if there is a crack or anything else in the tooth that could create this environment to be sensitive, and keep going on with the teeth bleaching. That's what I normally do when that kind of situation happens. Don't forget that anyway, tooth whitening diffuses in the tooth structure for around 48 hours. So if you have an extra coverage of your gum line or your sulcus and you feel like you're not getting the entire tooth surface bleached, don't worry about it. It will diffuse through the tooth, okay? I'm trying to look at all other questions that may be. Do you recommend placing MI paste or Prividin 5000 in the at-home trays after a session of at-home whitening? If I'm not mistaken, MI paste need to be rubbed on the teeth before, and Prividin, I would think it's the same. Toothpaste or paste are made to be rubbed on the tooth surface. You can leave them on the teeth. I would not use that while you're doing the bleaching just because they are mechanical desensitizer. Not only they're not that effective, but on top of that is that they may slow down your bleaching process. So keep up, while you're doing the bleaching, stay within potassium nitrate-based product. You can do the same with, like I said, the gel, but if it's not that sensitive, you can be just doing it with Sensodyne or any product that have potassium nitrate. But yes, you could do the Prividin 5000 or MI paste after to remineralize the tooth structure and get rid of any extra sensitivity that may left from tooth whitening. As I can see the good conservation of Pola office when I buy. Yes. Don't worry about Pola office. Normally, the conservation of the product is well taken care of. So no worries about it. Well, I think I've been through the entire list of questions at this point. Let me check if got something else. Do you recommend usage of Gluma or no, never. Gluma, I'm not a Gluma person. I'm all against the chemical that are being into the Gluma, and actually I'm going such against Gluma. I'm into glass ionomers product and all that kind of product that avoid sensitivity even under restoration. There is glass ionomer bonding now on the market. So no, Gluma, no, definitely not. Should you keep all whitening product in the fridge? Absolutely. Keeping your whitening products in the fridge just does extend the shelf life of them. So if you can, if you have the room, yes, do it. If you don't have the room, you don't have the fridge, just make sure they are in a fresh environment, which is not on the fridge or in the bathroom, or if you're in the office, you know, where the storage that is just next to the motors and the suctions and everything else where it's very hot. Be careful where you store your tooth whitening. It is an established catalyst in degradation of the H2O2. Yes, absolutely. It does speed up the breakdown of the hydrogen peroxide. So, totally. Do you think core is the most effective one to treat tetracycline stains? I think that what is the most effective tooth whitening is the one that a patient can keep in his mouth on an extended period of time. So it's not about the brand, it's about being able to do it on an everyday basis. It's about wearing it the longest as possible, and it's about being able to do it for extended period of time, weeks and weeks. So the best product for that would be the one that would have a neutral pH, would be the one that has a water content, would be the one that has the sensitizer in there, and that would be your best product. I'm not against core. I just think that for the cost it's going to come out for the patient, I don't know if it's all justify that hydramid thing. And by the way, I made a search on internet and on PubMed about hydramid. This is not even an existing word. It means nothing. It's just a combination of carbamide and hydrogen within their syringe, and they made that combination in the world calling it hydramid. But chemically wise, it doesn't even exist. So like I'm saying, core is not a bad product. It's just they're just super strong at marketing and explaining everything with fancy words to make you believe that it does work better than other. Like I'm saying, make good trays. Make them well sculpted. Make them that they hold in the mouth. Choose the right formulation with your patient. Do your reservoir, and you'll get the best result you can, I guarantee you. Why young people whiten better than older people? It's because of the type of stains. Older people have stains that have remained in the teeth for long. And that's what I explained. You can re-listen to my presentation. Listen, my time is over. I have to wrap up with you guys. It was a pleasure tonight to give you that information. I'm having another presentation much more dedicated to marketing next week. Same time, same day. So again, thank you very much. Feel very comfortable sending me your questions, contacting the webinar service to get in touch with me. It'll be a pleasure. Have a good evening. process